think empathy is a word that's overplayed in our industry significantly. I like to refer to it as having a heart for caring. And when I ran hospitals for 10 years as a CEO, when I interviewed people, regardless of what the position was, by the time that resume made it to my desk, I knew they were qualified. I would give it a 30-second look, and I would push it aside, and I'd ask them a couple questions because I wanted to hear their story. If I asked them 3 questions and I hadn't heard their story, they weren't the right candidate for me. And in nursing homes, that was even more true. If you're a hospital, you are the largest cost to yourself in the ACO. I made a lot of people uncomfortable at the USC C-Suite Invitational last year when I said, raise your hand if you're a CEO of a hospital. Raise your hand if you brought your ACO CEO. How much longer before you report to him before he reports to you? Because if the feds keep going down this path, you need to answer that question. As a hospital, stand alone, expand services, become part of a health system, partner with post-acute, skilled nursing, home health, whatever it might be. Here's the one I don't understand. Why aren't you calling me or these vendors in this room and saying, can you help me generate new revenue streams beyond inpatient revenue? I, for the life of me, can't understand why nobody's asking that. Because things have been so good in the fee-for-service, free-for-all, we didn't need to think outside the box. You better start thinking outside the box, folks, because inpatient revenue is going to go down, census is going to go down, everything's going to become managed care, pre-authorization is required, and one day, it's really simple. In my world, we called it core staffing. Your revenues no longer exceed your core staffing in America, a capitalistic society. We call that filing for BK or just closing your door. That is a certainty that your revenues will go down in this new model. So how are you approaching that? If you haven't researched artificial intelligence and what it can do for you as a risk-bearing entity, that's another thing that you've got to do, and you've got to do it today. Because AI is here, it's real, and if you want to know how to run a risk-bearing entity, you have to have the data that shows it. The former CMS Innovation Center director from about 5 years ago started a company called Patient Ping, which all over your community, anytime somebody shows up at one of your facilities, it sends a ping to everybody to say, hey, this patient just popped up over here. So if you're a risk-bearing entity, I've seen that be very good as well. I was sharing with somebody this morning that Abbott Nutrition has a voucher program that's free to the hospital that gives people free Ensure when they get home and tells them how to access it because it's keeping people out of the hospital. Remember, you're paying for these unnecessary hospitalizations. There is a fine line between patient choice and steering. They are not the same thing. And the attorneys that you paid and I paid convinced us of the opposite. They said, oh, you can't steer patients to this nursing home or that nursing home because they have a choice. 2 totally separate things. Let me summarize it for you. This is America. HMO or not, you can go wherever you want. You always will. That will never, ever change. You might have to pay a little more, but you can go there. That's patient choice. Will never go away. Steering, not only is it going away, but for those of you who don't read between the lines, the last 2 alternative payment models introduced by the federal government require your hospital to steer patients to certain post-acute providers.